the first thing to think about when thinking about where the future, what the future might look like for us, I think is we have to think about how far we've come, how quickly. So if you dial back in time, today is 2025. If you look back to 2013, that was the year of the very first research study ever published explicitly studying misophonia. 2013, so that's only 12 years ago. So in 12 years, what have we done? What has been done from a scientific perspective? And then from there, I think we can look to see what might we look forward to in the coming years, both scientifically and clinically. So the first thing to highlight, in my opinion, is that since 2013, we've come a long way. We have a consensus definition. We have a definition of what we call misophonia. Now, we can quibble with it, but we do have a starting point definition to work with. Prior to 2022, we actually didn't even have that. We didn't even have a definition that we all could say, this is what misophonia is. Again, we can quibble with it, and we should, but at least we have this starting point of a definition. The second thing that's happened in the last 12 years is that there are many different validated measurement tools. So tools to study misophonia, measures that are self-report, measures that are interview-based, measures that have statistical support as being valid, reliable ways to understand severity of misophonia, to understand how much it's impacting people, to understand things like the types of thoughts or the types of physical reactions or the types of emotions that people have, the types of behavioral responses they have, and so on and so forth. We have measures, and we actually have a bunch of them now to choose from. Related to that is that we have measures from around the world. So measures that started, let's say, being developed in English now have been translated and are being used across the world. And that's really important if we understand misophonia. We have to understand it across all people, not just some people. We know since 2013 that through large, rigorously done studies like Dr. Dixon's study, we know what the prevalence estimate is. And we have a pretty decent, it's probably imperfect, but a pretty decent, robust estimate. Even just a few years ago, people were estimating really big numbers. 20% of people in the world, 50% of people. Now, through really rigorous, well-done, large population studies, we see that the estimate is probably closer to 2 to 5%. That's a big number. That's a big number. 5% would be higher than many other disorders that are much more commonly understood and people are much more aware of. So don't be thinking that's a low number. That's actually a really high number, 2 to 5%. Another thing we know is through neuroimaging studies, we know that brain changes in response to triggers. So we know there's atypical connectivity. We know there's heightened brain responses. We know that this happens in various different networks and regions in the brain when people are triggered. That's really important. We also have a reasonable estimate about when we think misophonia is most likely to begin for most people. And it's childhood or early adolescence, perhaps young adulthood, but most people, not everybody. There's variance around that, with some experiencing onset early in childhood and some later on in adulthood. But the vast majority of studies are telling us happen in childhood to adolescence. Also, we know misophonia is not simply just a symptom of another disorder. It seems unique. It's correlated with other disorders, but it is not just a symptom of another disorder. We know through research that it's a global problem around the world. We know that it's a lifespan problem over time. We know people of all ages have misophonia. Young, early adulthood, middle adulthood, older adulthood, everybody of all ages processes, attentional processes, somatic in the body processes, interpersonal processes that affect relationships, and cognitive processes in terms of how people think. All of these different processes, which, by the way, spells the word basic, B-A-S-I-C, all of these are relevant to misophonia. not just one. And then lastly, we know from science that therapies can help. We know that some cognitive behavioral therapies seem to show some good promise in helping people with misophonia. So, okay, we know a lot. But what is the next? What's the future going to look like? What are we saying 10 years from now? Well, I hope in terms of research that we've got an updated definition of the consensus definition. A lot of research has been done since the consensus definition was written. We need to update that thing. We need to make it a little bit more nuanced, a little bit more up to date with what the current research says. We also, in the future, should expect to see much clearer differences between misophonia and other disorders. We know it's not hyperacusis. We know it's not OCD. We know it's not autism. But we need to do more research to cleave and carve these things apart really cleanly so we have good answers about where they overlap and where they're different. We really need in future research to study all people with misophonia. The studies of misophonia to date, it's kind of unfortunate to say this, but it's true. The vast majority of the research on misophonia is really research on misophonia in certain people, not all people. Who are those certain people? Well, they tend to be white. They don't tend to be all races, all ethnicities. They tend to be white people. They tend to be women, not men. They tend to be women, not men. They tend to be adults. Ironically, not children or teens, even though that's really when we expect this to start. They tend to be studies done in Western cultures and countries, not everywhere. So, look, the takeaway is we need to be really working hard in the science of misophonia to understand misophonia in all people, not just some. We need to understand the cross-cultural differences scientifically, how misophonia expresses itself differently in certain cultures and certain countries compared to others. We know misophonia is present around the world, but we don't really understand how it differs in its expression. And that's really critical, scientifically speaking, if we're going to end up understanding how to identify, prevent, intervene, and so on. We need to understand the effects of misophonia on relationships, on interpersonal functioning. We know that misophonia causes havoc interpersonally. We know that scientifically. There's a lot of studies actually that have shown misophonia is related to increased interpersonal problems. What we don't really understand is the specificity of those problems and how we can intervene to change those interpersonal processes. We need that scientifically. We're just beginning to see subtypes emerge. So we're seeing in a study this last year, first evidence of what we might call anticipators versus reactors as two possible subtypes. This is a really great study done at Utah State, but we need more research. We need to understand, are there different subtypes of misophonia? Or maybe there's individualized differences in how people experience and express or what's going on inside of the bodies and the brains of people who all might have misophonia. In other words, maybe the assumption that misophonia is the same for all people with misophonia, maybe that's the wrong assumption. And we might look at individual differences beyond subtypes. Maybe there's individual differences that are really important, and we need to understand that scientifically. Research moving forward really needs to let the lived experience of misophonia guide the research questions. We're starting to see a movement in this area, and we need much more of this. We also, of course, need to have research build, test, iterate, revise, continue building new treatment approaches. There's all sorts of new ideas out there that people have. Some people have studied these ideas, some people haven't. What we need is scientific testing of people's ideas about what might help misophonia. Duke, for example, we are piloting an AI-based digital device to suppress sounds in real time, to suppress semantically organized classes of trigger sounds in real time, allowing the person to hear everything else around them, but not hear their trigger sound in real time. Now, this is obviously just a sort of an idea. We're doing this with the folks at the University of Washington who have this technology. This could be a useful coping strategy, a useful coping skill as part of a suite of approaches to manage misophonia. But we have to test that. We have to really push and test and understand if it can be helpful before we can actually get it out into the world to try to help people. We can also scientifically adapt current treatments. So for example, neurostimulation is a current treatment for lots of disorders. Neurostimulation can be potentially adapted for misophonia. And my colleague here at Duke is leading the charge in this front, Dr. Andrada Nekshu. She's doing really great work looking at neurostimulation and misophonia. And the same thing is true for behavioral therapies. There's behavioral therapies that work for lots of disorders. You heard Dr. Lewin talk about the unified protocol. Perfect example of this. Works really well transdiagnostically for lots of disorders. We may not need to invent a new wheel. We might need to take a current wheel, tweak it, adjust it with lived experience guidance, test it, and then put it out there into the world. And all of these treatment studies scientifically over the next 10 years, they need to be driven by really well conducted, large, controlled trials. We can't continue to only have small trials that give us promise. We need definitive trials. And lastly, I'll be quick here on the future of clinical care. I envision a future where misophonia is included in the ICD-11 as a diagnosis. It's currently under review for inclusion. My hope is that it will be included, and this will be a diagnosis that can be seen as legitimate by all doctors everywhere in the world, because that's what the ICD does. It legitimizes a condition and a diagnosis for doctors everywhere around the world and healthcare providers everywhere around the world. The future of clinical care for misophonia hopefully also will include significantly raised awareness among doctors and healthcare providers. Today's Care Day event is one step towards doing that, and we need everybody to be pitching in to achieve this really important goal. Similarly, we need to increase clinician education about misophonia. Many of us involved with this are very dedicated to that mission, and we all need to be doing this to try to increase clinician awareness and clinician education about what it is and what it isn't. This might help to, in the future of clinical care, screening and referral care pathways, so that when you go see your pediatrician, perhaps there's a way to screen for misophonia and then get recommendations for reasonable, credible, evidence-based care pathways. Of course, to have that, the future of clinical care must include training clinicians for what to do to provide that downstream treatment after screening and referrals happen. To do that, the future of care really must include expanded access, clinician referral networks, an expansion of that, and a real dedication by a lot of us to make that happen. As we expand treatment options, we need to include these options to people clinically who are really among different subgroups or subtypes, different identities, different cultures, different countries, perhaps different subtypes of people. We really need to not think of misophonia clinically as something that warrants a one-size-fits-all treatment. It's probably not the way to think about this. It probably makes sense to think about treatment of misophonia by understanding for each person what their unique and individual problems are in the patterns underlying their misophonia, and then provide interventions to change those patterns. The future of clinical care, we hope, also includes the gathering and the amplification of stakeholder voices. Stakeholder voices to affect policies for funding, stakeholder voices to affect policies for community spaces that can be safe for people. All of this, we think, can be the future of care for misophonia. Two last bits, and then I'll sign off on this. Early identification and early intervention with families and with children is absolutely essential to the future of clinical care. Dr. Lewin's great work that he presented just a few minutes ago, that is a great step in this direction, but that's the first study. That's the first RCT, the first randomized controlled trial evaluating an intervention for kids with misophonia. We need more. We need more. We need much more of this. Last, The future of clinical care for misophonia needs to, and I don't know about you all, but I really envision this future where what we have are evidence-based, flexible, evidence-based clinical care pathways integrated into multidisciplinary care models where you have screening in pediatrics or primary care, referral to audiology, occupational therapy, and or mental health, and then specific, discipline-specific interventions that can help on that front. We need all of those things to be able to have ultimately the kind of clinical care pathways that every parent that's here today and every parent of a child with misophonia expects and I think deserves. And the same is true for adults with misophonia. We need you to be able to get to your doctor or your healthcare provider. They need to not just know what it is, but have a way to screen, to refer, and to refer to a trustworthy source. Now, these things are all things I think can happen in the next 10 years. Look at how far we came in the first 12 years. I think we can do all these things together. We all have to pitch in, we all have to push, we all have to work really hard, but this is a fantastic community, and I believe in us. I'm going to stop us here. I apologize for going over a few minutes. It's what I do sometimes. I get passionate. What can I say? We'll see you all in the next session. Let's keep this conversation going, guys.